This talk will focus on medications for alcohol use disorder, and this will be from a primary care perspective. I'm Dan Jonas. I'm a primary care physician in general internal medicine and a health services researcher, and I lead the Stop Unhealthy Alcohol Use Now program along with a great team. And one of the things we're working on is helping to screen in primary care practices for unhealthy alcohol use. And some people who are identified to have unhealthy alcohol use will have an alcohol use disorder and might be good candidates for medication. It's important to revisit and clarify some definitions that I'll be using throughout the talk. First, unhealthy alcohol use is an overarching term that includes risky drinking as well as alcohol use disorder. Within that overarching term, risky use is consumption levels that increase the risk for health consequences and consumption above the maximum recommended daily or weekly limit. Those are shown in the pop-up there, and you can see that they're different by sex and by age for men and women and based on a threshold of 65 years. Now, alcohol use disorder is defined by DSM-5 criteria, and I'll show those on the next slide. But I wanted to also mention that there are some terms that people might be familiar with that are somewhat older and have been in the literature and were in the previous iteration of the DSM. And those are alcohol abuse and alcohol dependence. Those have been removed from the DSM-5 and they're combined into this one entity called alcohol use disorder. Here are those DSM-5 criteria. You can see that there are 11 criteria. I won't go through all of those, but I'll say a few things just to highlight something that's new. So if you're familiar with the criteria, that's been pretty long-standing. There were a few changes in the DSM-5. One is that they added craving or a strong desire or urge to use alcohol. That wasn't in the DSM-4 version of the criteria. And they also removed the criteria that's related to legal issues. And then they added severity categories. And you can see those at the bottom of the screen. So to meet the criteria for an alcohol use disorder, a person has to have at least 2 of the 11 criteria. And then the severity of the alcohol use disorder is determined based on the number of criteria that are met. So a mild alcohol use disorder is 2 to 3 of those criteria, moderate is 4 to 5, and severe is 6 or more. It's important to have these terms in mind and these categories in mind of risky drinking and alcohol use disorder that I just defined, because whether a person has one or the other of those really leads us down a different pathway clinically. So on the left, if a person has risky drinking but they don't have an alcohol use disorder, then the appropriate intervention is counseling in primary care. On the right then, if a person has alcohol use disorder, some of the common treatments are cognitive behavioral therapy, motivational enhancement therapy, 12-step programs, or pharmacotherapy. And that pharmacotherapy is going to be the focus of today. Before I get into it, though, a little bit more about how to determine if someone has an alcohol use disorder or risky drinking. One of the tools that we use clinically in primary care and that many practices use is called the audit, or the Alcohol Use Disorders Identification Test. It is shown here. It's 10 questions. And the first 3 questions focus on the quantity and frequency of alcohol use. The next 3 are really trying to focus on identifying an alcohol use disorder. And the last 4 questions are about alcohol-related harm. And the audit covers a year-long look back, so it can detect alcohol problems experienced in the prior year. Also, it can be used as a second step in screening. So many practices use a shorter questionnaire before using the full audit. The audit is really helpful in what we refer to oftentimes as screening-related assessment. So we have a patient who's had a positive screen, and then we're trying to sort through whether they have risky drinking or an alcohol use disorder, because as I mentioned a little bit ago, those 2 categorizations lead us to different appropriate clinical interventions. This is on the backside of our paper version of the audit that we use, and many practices use a similar version. And this is a clinical decision support tool that helps take the total audit score and convert it then into the categorization of whether someone has an alcohol use disorder or whether they probably don't. So you can see in that first row, scores of less than 6 or less than 4. an alcohol use disorder is very unlikely, and we would proceed with counseling for risky drinking. And then in that bottom row of scores of 15 or more or 13 or more, an alcohol use disorder is very likely, and we would consider CBT or some of those other more intensive interventions, and we'd be considering pharmacotherapy. In that middle row is a little more challenging because it's a wide range of scores from 6 to 14 for men and from 4 to 12 for women. If that's the score, then we have to really zoom in on those questions 4 through 6, which are focused on identifying an alcohol use disorder, and determine if there were at least 2 points that came from those 3 questions. And if there was, an alcohol use disorder is considered to be likely. And those questions are about whether someone was able to stop drinking once they had started, whether they failed to do what was normally expected of them because of drinking, and whether they needed a first drink in the morning to try to get going after a heavy drinking session. All right, shifting to some of the specific medications that we might use in primary care to treat alcohol use disorder. And I'll give the bottom line key point here at the beginning and before I dive into a little bit more detail. Naltrexone and acamprosate are 2 medications that are both effective for preventing lapse, which is return to drinking, and for reducing consumption of alcohol for people with alcohol use disorders. There are actually 3 FDA-approved medications: acamprosate, disulfiram, and naltrexone. Acamprosate in the first row here is thought to modulate NMDA receptors as far as its mechanism, although there's some uncertainty about all the different ways that it actually works. It's dosed at 666 milligrams 3 times a day. Disulfiram is the one of these that's been around the longest, and it's somewhat infamous for its mechanism of action, because it causes a very uncomfortable set of symptoms if someone is taking the medication and then they consume some alcohol. So they get nausea, dizziness, flushing, tachycardia, and a number of other very uncomfortable things. Then naltrexone in the bottom row is an opioid antagonist, and it competitively binds to opioid receptors to cause its effect. It's got both an oral and an intramuscular injection formulation. We published this article a few years ago that was a systematic review and meta-analysis of these medications for alcohol use disorder in outpatient settings. And it was surprising and impressive how many randomized clinical trials there are of some of these medications. So for acamprosate, and this was several years ago, there were already 27 randomized clinical trials with over 7,500 participants. And for naltrexone, there were 53 randomized clinical trials with over 9,000 participants in those studies. Most of the trials in this meta-analysis enrolled people who had gone through a detoxification or were required to have a period of sobriety for at least 3 days. Participants enrolled in the studies generally had alcohol dependence. So I mentioned that term earlier as being an older term. In today's terminology, what that tells us is these people probably had a moderate to severe alcohol use disorder. And the folks with mild alcohol use disorder weren't well represented in these trials. So there's some uncertainty about whether the medications would be appropriate for mild alcohol use disorder. And then the last bullet there, these studies typically included psychosocial co-interventions. And so the effect sizes from these meta-analyses reflect the added benefit of medications beyond those of psychosocial interventions and beyond those of placebo. So here's some of the key results of the meta-analyses, and I'll just highlight a few things. One is for acamprosate and naltrexone, the number needed to treat to get one person to not return to any drinking or to not return to heavy drinking ranged from 12 to 20. So pretty effective medications when you look at numbers needed to treat across a lot of different bodies of literature. But that also reminds us that most people who are treated with the medication won't benefit from it, actually. And the numbers needed to treat here represent the added benefit of the medication beyond the benefits of psychosocial co-intervention. There are some contraindications that are very important to note. So for naltrexone, acute hepatitis or liver failure are contraindications, and there are also precautions for other liver diseases. And the other important contraindications is current use of opioids or anticipated need for opioids. And the reason for that with the competitive mechanism of naltrexone is that it can precipitate a severe withdrawal syndrome. And then for acamprosate, the contraindication is severe renal impairment, and it also requires some dose adjustments for moderate renal impairment. So what are the common adverse effects of these medications? For naltrexone, there are anxiety, diarrhea, and vomiting. And you see the numbers needed to harm there anywhere from 7 to 42. So if we treat 7 people with naltrexone, we'd expect 1 person to have some side effect of some anxiety. And then for acamprosate, numbers needed to harm 9 to 24 for nausea, dizziness, and vomiting. I'll say there's not as much data on harms as there was on benefits, but one of the things that stood out in some of the data and in a lot of clinical series that have described naltrexone use is that if you start at a lower dose for the first week or 2 of 25 milligrams, that can really mitigate and decrease the frequency of the side effects. So how should we select a medication in primary care when we've got several options? Well, the head-to-head randomized trials have not consistently established one of them as being superior to the other as far as the benefits go. But we think there are several reasons to favor oral naltrexone unless there's a contraindication. And the main one of those is administration frequency. Oral naltrexone is 1 pill once daily, whereas acamprosate is 6 pills a day. So you've got to take 2 333 milligram tablets 3 times daily. And cost for both of these is really low, actually, because they're both available in generic form. I do want to mention one off-label medication, topiramate, that has a lot of emerging evidence that it can also reduce drinking days and heavy drinking days for alcohol use disorder. It's not FDA approved, but many experts who treat alcohol use disorder actually consider it to be their second choice, where they start with naltrexone, and then if naltrexone isn't beneficial or if there's a side effect, then they actually go to topiramate as their second option, partly because of just the frequency of medications that have to be taken with the 3 times a day for acamprosate. And then I'll just wrap up with the key points for this. So naltrexone and acamprosate are both effective for preventing a return to drinking and for reducing consumption for people with alcohol use disorders. And they're fairly easy to use within primary care settings, and they can help a lot of people with alcohol use disorders.